Good. Welcome everybody, and thanks to the organizing committee to invite me. Sorry for my voice, I have a bit of a cold, so my voice is not that optimal. I'm going to present to you a lecture or a presentation about the role of abdominal muscle recruitment in athletes with long-standing adduction-related groin pain. Chicken or egg? It was noted before. A lot of uncertainties on that aspect. First, I'd like to, of course, thank the organizing committee for the invitation. I'm from Eindhoven at this moment. We do have a stadium, the PSV stadium. We do have some architecture, but we cannot compete with Qatar in the hotel we were in. So, thank you. The outline, I'll start with some background, but I guess that's pretty familiar for all of you. Some background information on the association between between groin pain in athletes and pregnancy-related pelvic girdle pain. Then we're going to talk about the abdominal recruitment and finally the clinical implications. Start off with the background. Groin pain, as you all know, is a vague symptom in a vaguely described area. It has a variety of symptoms from related to the iliopsoas, to the inguinal hernia, to the adductor muscles, a lot of variety. But as research has shown, mostly pain is associated with hip adduction. That's the most provocative test. What is noticeable is that the adduction provocation tests are also used in women with pregnancy-related pelvic girdle pain. So whether it's the squeeze test that is in this picture or it's another long adductor provocation test, both provoke the adductor muscles. And beside the adductor muscle provocation test, there is the active straight leg raise test, which was described by Jaap Jansen et al., where a subject is lying on their back and is asked to lift the leg for about 20 centimeters. Both tests are used in both groups. Why? Why is that? Now, first we have to look at the biomechanics of an isometric adduction test. In this case, the patient is lying in this position and is asked to squeeze both legs with maximum effort. This will give him a certain amount of effort, so force can be measured, and it will deliver a certain amount of pain. What we see is people have little force, little strength, and mostly quite a lot of pain during this test. During the active straight leg raise test, a subject is just asked, what I said before, to lift one leg, and difficulty is evaluated on a 0 to 5 scale per leg. So you can obtain a total score of 0 to 10, and the test is positive if the score is bigger than 1. Not yeah. It's off. Thank you. So let's go into the biomechanics of those tests to explain if we can see similarities between pregnancy-related girdle pain and groin pain in athletes. If we look at the biomechanics, a subject is asked to squeeze, and this strength is delivered by the adductor muscles. From a biomechanical perspective, you can just, since it's an isometric non-moving activity, the reaction forces are directed in that way, and if you explain or distract these forces, you can see that there is actually a force distracting the pubic symphysis. So, and there might be a similarity between pregnancy-related pelvic girdle pain. When we look at the active straight leg raise test, subjects are asked to lift one leg, and the rectus femoris will, in the theory, lead to an anterior rotation of the ilium, therefore provoking the pubic symphysis as well, in both athletes with groin pain, adductor-related groin pain, and women with pregnancy-related girdle pain. The next similarity, we know that in both groups, wearing a pelvic belt decreases symptoms in pregnancy-related pelvic girdle pain, but also in athletes with groin pain. What we see in a research done by Jan Mens et al., that in 68% of patients with groin pain, performance will increase, so less pain and more strength when subjects are wearing a pelvic belt. And the biomechanical explanation is that the belt will compress the anterior pelvis, so therefore compensating the distracting forces of the adductor muscles. The same is true, the same reasoning is valid for the pelvic belt effects in the active straight leg raise test. In a group of patients with long-standing groin pain, 32% of those patients had a positive active straight leg raise test, so about 1/3. When you put on a pelvic belt in these subjects, all these subjects improve in their performance with a belt. So there must be something going on with the pelvis in this group. The distracting of the force of the biceps, the rectus femoris, will maybe, in theory, not lead to anterior rotation of the pelvis, of the ilium. So, to summarize the background, there are symptoms of pain during forceful adduction in both athletes with groin pain and in patients with pregnancy-related pelvic girdle pain. An active straight leg raise test is sometimes positive in athletes with groin pain, and it's the same in pregnancy-related pelvic girdle pain. And we know that wearing a pelvic belt decreases both symptoms in terms of strength, and so an increase in strength and a decrease in pain. And from an anatomical perspective, we know that the deep abdominal muscles anatomically represent a pelvic belt. And that's the whole idea how we got to the dysfunction, possible dysfunction of the deep abdominal muscles in pelvic, adductor-related groin pain. So, I'm going to tell you about dysfunction of the abdominal muscle recruitment in this patient group, and I'm going to shortly discuss findings using electromyography and ultrasound. I'll start off with the findings on electromyography, not a study done by me, but by Cohen in 2004. They used a cross-sectional design and included 15 patients and 15 controls. The patients all had to have adduction-related pain, so pain provoked during isometric adduction. And they asked the patients to do an active straight leg raise when a certain light went on. So they had to respond as quickly as possible with an active straight leg raise once the light switched on. And they measured EMG of rectus femoris, transversus abdominis, internal oblique, and external oblique, and rectus abdominis. And what they found for transversus abdominis, that in the healthy subjects, the transversus abdominis is active before the onset of the rectus femoris. In this case, the rectus femoris is considered the prime mover of the active straight leg raise. And in patients, as you see on this side, the rectus femoris is active prior to the transversus abdominis. So there is a delay in activity of transversus abdominis. So that was the first suggestion, okay, there's something going on with the deep abdominal muscles in this group. When we look at our findings, this is a study that we did, in collaboration with Adam. Again, we used a cross-sectional design. In this case, we measured thickness of abdominal muscles during various tasks using ultrasonography or ultrasound. We measured values in resting values, during active straight leg raise, and during isometric hip adduction, so the squeeze test. What we found is a significant difference in resting value of transversus abdominis in athletes, independent of the side of complaints. We always measured on the right side. Whether they have left side complaints or right side complaints, the transversus abdominis was significantly less thick compared with healthy matched controls. That was a finding we thought was interesting. On the other hand, since Cohen found some results, some differences on recruitment, we expected also to find some differences on recruitment expressed in ultrasound measures, as the percentage increase of thickness during various tasks. So here are the various tasks: active straight leg raise, left, right, adduction, and other muscles. And here you see very similar values, and we did not find any significant differences using these outcome measures between controls and left side complaints and right side complaints groups. What we further did is we used a prospective study design where we evaluated a number of patients and we treated them with physical therapy using a kinetic chain approach. So what the physiotherapist considered relevant, possibly a hip, a range of motion decrease, the physiotherapist was permitted to do range of motion exercises. A sacroiliac dysfunction manipulation was allowed. But we also included specific trunk stabilizing exercises to specifically recruit transversus abdominis to increase activity of that muscle during the various tasks. What we found is that, yes, we found a significant increase in transversus abdominis resting thickness. But we did not find any significant changes in transversus abdominis recruitment. So it's, again, very similar. Before and after treatment, ultrasound findings, we did not find anything. A next thing we tested is there an association between the transversus abdominis thickness change, so how much do they increase, and the change in 5 minutes? Okay. And the change in self-reported sports restriction. And there we did find a significant association. So what we only found it for resting thickness. So we expected relations to be like this. And the more increase in abdominal muscle thickness, the more increase in performance. It's defined negative, but that's because we defined the outcome negative, but that's the main idea. In terms of recruitment, we hoped to find similar results. But there we found this, and it was a bit chaotic. Because there were absolutely no consistent results that improving transversus abdominis recruitment during active straight leg raise or during hip adduction would lead to better injury status, so better performance. So, we can identify abnormal abdominal muscle values in terms of EMG or resting values. And the resting changes in resting thickness are associated with recovery, but what is the chicken or the egg? We have no idea. The question was asked before. Therefore, we did another study on the effects of anticipated pain. Does pain anticipation affect abdominal muscle recruitment? We used 14 volunteers who were crazy enough to participate. We used electrostimulation and measured abdominal muscle recruitment again by ultrasonography. And what we found is that yes, groin pain anticipation leads to adaptation in deep abdominal muscle recruitment. So we concluded that pelvic instability is not required per se to alter abdominal muscle behavior. So the chicken or the egg, yeah, it could be the consequence of having pain or having a threat to pain. We did find it consistently in both active straight leg raise in the gray bars and adduction in the black bars. This is anticipation of pain, this is the reference condition, and we see a big decrease in relative thickness. But on the there was a parallel with back pain research where they did similar research. A lot is done by Hodges from Australia and Mosley is also from Australia, I guess, who did a study on anticipation of back pain. And they found out that transversus abdominis is actually delayed when there is an anticipation of back pain. So a change in muscle recruitment can certainly be the consequence of experiencing a threat of pain. On the other hand, there is limited evidence because it's really difficult to study this. But you can, there is some suggestive evidence that if you only use abdominal bracing strategy, so use the Valsalva maneuver to prepare yourself for certain movement, that will lead to a change in abdominal muscle recruitment in terms of a delay of transversus abdominis. So if that's your strategy, you have a suboptimal recruitment of suboptimal. It's potentially a risk factor for developing complaints. And that's what actually Jan Mens found in his clinical practice, but he's been mainly working with pregnancy-related girdle pain, that's a common pattern. But is that ineffective? Because bracing is done by a lot of people. Yes, it is effective. It will lead to an increased stiffness of your pelvis ring as soon as you start bracing yourself, but it is not as effective as doing an abdominal hollowing maneuver. So, in terms of clinical implications, there might be an entrance for us. But is it really required? Since we know that we suggest that pain is causing a change in abdominal muscle recruitment, do we need to give specific attention to it? Since we know that maybe if we just put the pain away, then the muscle recruitment will change to the normal recruitment patterns as well. And that's also studied by Mosley in 2006. But he showed that when people have sufficient variability in their motor behavior, they will automatically return to their normal motor patterns. Except for subjects with high fear avoidance beliefs. They really have trouble getting back to their normal abdominal recruitment patterns, and they will stay in their faulty patterns. So, for the clinic, for physiotherapy, I think it's important to check injury coping style and consider specific additional core stability exercises or transverse abdominis multivity recruitment if this is the case. If a patient has a good coping strategy with his complaint, I don't think it will give you a lot of additional value. And furthermore, I think it's important to use a gradual progression in stabilizing kinetic chain exercises according to Per Holmy's study in 1999. Use a pain contingent approach. So do not train over the pain, because pain might lead to a disadvantageous muscle recruitment pattern. Future research, maybe half a minute or so. We need to check what is normal or abnormal muscle recruitment under high load circumstances. All the tests that are done are on very low load, so we have no idea what everybody doing during sports. How do we do motor teaching? Do we need to give extra attention to muscle recruitment patterns, or is it absolutely no additional value? And finally, a result of a randomized controlled trial, but it's not discussed right now, is there an additional effect of muscle recruitment exercises for athletes with groin pain? We don't know yet. Thank you very much. This is a picture of our June bashing trip yesterday, and it was great. Thank you for the invitation.